I want to welcome you to another Facebook and YouTube Live. And if you're checking this out for the first time, this live stream we do every month on KeithRN, Think Like a Nurse, is to support and serve the needs of nurse educators in the trenches, to empower you with practical and educational best practice strategies, to develop clinical judgment and other essential competencies so our graduate nurses are better prepared for real-world practice. We haven't met. My name is Keith. I'm the founder of KeithRN. And if you're not familiar with KeithRN, you need to be, because my passion is really to help support the needs of nurse educators by providing you with innovative resources, including very unique unfolding case studies that replicate the thinking of clinical practice like no other. So again, our graduates are prepared for practice. And we really need to practice the thinking of practice. And that's really my passion, and really transforming nursing education one educator at a time. And how do we do that? By simply changing the way we teach in our classrooms or in our clinical settings. Literally in all that we do, we must radically change and transform the way we teach nursing. And so I'd like to know who's with us tonight. I've got Dr. P already said in the chat, this is going to be so good. So you must be licking your chops, as we're going to be talking tonight about innovating clinical education, and really kind of talk about the problems that we're facing in nursing education in developing clinical teaching, or developing that clinical judgment in the clinical setting, as well as other essential competencies. And that'll be our focus tonight. And so I'm so glad you're here. If you just want to share, put your name and your state or anything in the chat, or just say hello. Let us know you're out there. When we do these virtual Facebook Lives, I know you're out there, but it's good. It's kind of like when you put the face on, when you go into Zoom Live, you kind of like, people just don't want to put their face, and you feel, well, where are they? And it doesn't feel quite as intimate. And again, I'm not, if you're comfortable, I just want to please share. Love to have you there. Last month we also talked about clinical teaching and best practices to, in essence, to, again, just talking about strengthening how we teach clinical. It's a hot topic. We need to go there. Last Facebook Live a month ago, as well as all the ones we've been doing the last 3 to 4 years, are on our Facebook Live, are on the YouTube channel, Think Like a Nurse. They're also on our Facebook group, as well as we have a nurse educator group that every one of you should consider being a part of if you're not already, and that's Teachers Transforming Nursing Education. I'm blessed to be the admin with over 18,000 clinical, as well as any nurse educator is welcome. And so I'm so excited to be a part of that, and for you, because that's a supportive community. We all need that support, and I'm so thankful to have you all here. And so I just want to say, this is really powerful. We've got a lot of people here tonight. We've got Kim from Trinity College, Christine in Texas, Michelle in Texas, another Texan, Beth Corner. I'm a fan of yours, Beth. Thanks for popping in tonight. I think you'll like our topic. Shannon in Yorktown, Rachel, yes, one of the content creators of our clinical course we'll talk about a little bit later, and others here. So I just wanted to say thank you. And it's such a pleasure to have you all here tonight. Even got we got even, I think, someone from Canada. And so love to have you here, Kimmy. Thank you for joining us. Pleasure. Well, I am basically going to start by just introducing our nurse educator consultant, Maria Flores Harris. And Maria, thanks for joining us tonight. And just want you to just briefly share your role with KeithRN and how you support the needs of educators, and anything else you'd like to share real quick.
Certainly. Hi, welcome everyone. My name is Maria Flores Harris, and I am the nurse education consultant for KeithRN. Basically, I do 2 main things. One, if you are interested in our Think Like a Nurse membership and you have questions about it, or you want a demo, please reach out to me. My email is Maria, M-A-R-I-A, @KeithRN.com. So that's easy to remember. Also, if you're already a member of our Think Like a Nurse and you have questions, or you want an update on our recent upgrades and additions to the site, we made some great additions recently. We have student-facing webinars. We have a student success course. If you would like updates on that, let me know. I'm here to help. Also, if you want an orientation, if you're fairly new to the membership, I'm here to support you and your faculty and your colleagues. Also, I offer faculty development, and we recently added some additional individualized faculty development for our members of the Think Like a Nurse. So if you are a departmental member and you're interested in additional faculty development, feel free to reach out to me. And again, my email is maria@KeithRN.com. So I look forward to hearing from some of you and would love to work with you and your faculty.
Yeah, thanks so much, Maria. And, in the membership platform, you have over 350 unfolding case studies and other resources that your students get access to at no additional cost to, again, practice the thinking of practice. And so I'm going to bring in one more guest tonight. I'm excited to have with us Lisa Gonzalez. Lisa is a friend and colleague, and she has been pursuing her PhD for too long. And she's just out there, but she's an innovator in nursing education. She's written some must-read articles for all of you in nursing education. One of my favorites of Lisa's, I'm just going to pop it in the chat and share some love, is basically teaching clinical reasoning piece by piece, using Tanner's framework and operationalizing that to really just develop a focus on specific clinicals, specific skills of clinical judgment in the clinical setting week by week. And I'm also going to share one more article that Lisa's written in 2021, Developing Students' Clinical Reasoning Skills, a Faculty Guide. And so, Lisa, you teach in Maryland. I'm looking to see on my bio here at the College of Southern Maryland. Got it. And she's passionate, she's innovative. And the most important role that Lisa has is she's a mother of 5 children, and she homeschools them, or 4. I'm sorry.
4 girls.
4 girls. She homeschools them, full-time educator, goes to school. I don't know how you do it, Lisa, but if I had a hat.
Education is our whole world in my family.
Yes. So thank you. And so it's good to have you here with us. And, we'll be talking about a clinical course that KeithRN has developed and will be published online later this year. But Lisa's been a key person who has helped to develop the outline for helping just a comprehensive solution to teach clinical for new faculty, an expert nurse, but a novice educator, or for any adjunct faculty. It'll be a powerful and practical resource. We'll talk about that in our second half. But before we anything, we need to talk about the problem before we can talk about solutions. And one thing we're going to talk about today, and it is kind of painful, is the challenges that we are seeing in nursing practice with not just new nurses, but nursing in general. And we had a Facebook post in the Facebook group, Teachers Transforming Nursing Education. We had a post about a week and a half ago that just blew up with over 200 comments. And I'm going to share the post link. If you have access to the members to our Facebook group, here is the actual post that all of you can go to. Now, if you're currently not a member of Teachers Transforming Nursing Education, here's your chance. I'll share that link as well real quickly, and you can basically cross that base and then use that link. But let me share this comment. And she says this was the initial post. Okay, have I missed something? My daughter just had major orthopedic surgery, and we've gone through 2 12-hour shifts and are at a well-known hospital in Manhattan. Not one nurse put a stethoscope on her, not to check bowel sounds, not to listen to her lungs. After getting a fluid bolus for low urine output, they don't even have stethoscopes around their necks. But I guarantee you, if I see nurses' notes, everyone is charting normal bowel sounds and clear breath sounds. And that blew up. And we, Maria, I'm going to let you kind of share some of the synthesis of comments. I read through most of them. Maria, I know, did as well. This is something that kind of it resonated for the wrong reasons. And we kind of got to talk about this and kind of get under the skin of what is going on. It's why? Just like anything in nursing education, we have to kind of dig deep and say, it's not just the information. Why is this problem present? Let's get beneath the waterline. And I want you to be a part of this discussion. Those that are attending live, I want you to share your why. But Maria, I want to start with you. And Lisa, I want you to jump in as well, because I know that you're passionate about this as well. But, what was, just kind of share some of your insights, the themes, and just your thoughts on this on a hot topic.
Oh, I don't want to share too much because I'll get wound up and I'll get angry and then I'll get sad, and because it was very sad. It was very disheartening to read. As Keith mentioned, there were over 200 comments within, I think, like just a day or two, and unfortunately, I think about half of those were sharing similar stories, and that was what was so disheartening. It's one thing for us to make a mistake because we're all human, and we are going to make errors because we are human. We are, fallible human beings. But to purposely omit or purposely do something that could harm a patient is not what we're about as nurses. So I don't know if I encourage you to go read it or not, because honestly, it makes me want to tear up now just talking about it. But what it also did is it's ignited a passion in me to get back into education and to really hit home. It really hit home how important it is, the work that we do as nurse educators. Because I will share this one last thing. One thing I always remember from Patricia Benner's book from 2010, Call for Radical Transformation in Education. I remember them saying in that book, I don't think it was Benner, I think it was one of her co-authors who said this, but she said, nurses are a patient's last line of defense. And I will never forget reading that. I thought, wow, that is so true. Well, if a nurse is a patient's last line of defense, then nurse educators are a patient's first line of defense. It is our duty and responsibility and obligation to make sure that we're doing our part to put out good nurses. And I'll leave it at that.
Amen. No, that's powerful, Maria. Lisa, what are your thoughts?
Yeah. Well, I read briefly through the comments too, and just like Maria said, just to hear that, it wasn't just one story. It was up too many stories, to the point when I was reading, I was almost like, wow, this is becoming like the norm. People are just you go, and honestly, I feel like I've seen this before a little bit in the medical community, but just to hear from nurses that we're doing this as well, and I'm just like, are you kidding me? And so I know for me, we're teaching clinical reasoning. We're teaching our students how to think through, how to advocate for patients, right? And so I've been doing this for a little while, and I actually had left practice but to teach full time, but I do still teach clinical. But during COVID, they asked nurses to come back to practice to help and all these things. And I remember when I went back to practice for a little bit to help, where I started to see some of these things. Like somebody who was training me actually said, well, yeah, we just clicked that we saw this and documented it. And if it becomes a problem, then we'll just change our documentation on like this task list. And I was just like, when did this become, what we do? I don't understand. And then just the fact that there is so many task lists, I'm like, wow, we're teaching nurses how to think, how to make decisions. And it's just becoming, we say, don't treat it like a checkbox, but that's how the computer system is set up with these task lists, just like a checkbox. And I think sometimes nurses get under pressure. They get into this routine of just checking tasks and checking things that, where's the room for the thinking, and where's the room for the independent nursing judgments? And so I was really disheartened. I feel like I agree with you, Maria. I think that this is going to be something that we're going to need to address with our students, because if this has become kind of like something that you see in practice, almost that it's so normal that this is happening, then that means our students coming into practice are going to have to be that much stronger, that much more empowered, that much more of an advocate to say, no, we can't do these things. And if there's a reason why nurses feel like they need to take these shortcuts, then we need to be able to push back and change the system and the structure then. So that's where some of my thoughts.
Yeah. And, as some of the thoughts that I had thinking about, at least, is, it's like, why are, it's the power of role modeling. This is what we need. I mean, when you look at role modeling, I think we underestimate its influence. Now, what we're seeing in this instance is that we're seeing we don't teach our students to do this. None of us as nurse educators are teaching our students to take these kinds of shortcuts ever. So where are they learning this? It's what's role modeled in practice. And they're seeing it role modeled by other nurses, which gives them unspoken permission to do the same. But in essence, we need to kind of flip the tables on this and say our examples and our communication, and we communicate why we don't take these shortcuts. As you know, in practice, sometimes you nurses can sabotage the best that we're trying to do as educators by the examples they see of incivility, bullying, shortcuts in practice, that their students are kind of like wondering, what do I do? What's the right way? Well, we need to be very intentional. I think that, to me, is a takeaway. We need to really recognize the power of our role modeling, for good or for bad, that we can be a part of that positive change. But we also need to communicate to our students, I believe, why we don't take these shortcuts. It's kind of like the temptations you're going to see all around you in this world. It's like there's temptations to take these shortcuts. But I think it's important that we communicate clearly why we don't do this, because of its impact on patient outcomes, as well as integrity, our professional values. I mean, we've just got to kind of, I think, we need to talk about these elephants in our clinical post-conferences or in any context. So again, we're role modeling what is positive and communicating the why in a very clear way. And so that's just kind of, my thoughts. As you look at the why, or other aspects of what we're seeing, is there, is it staffing? I mean, why are we seeing well-intended nurses taking these shortcuts in practice that's becoming normative? Any thoughts, Lisa or Maria, on that thought? What's motivating this? Is it laziness? Is it a lack of ethical integrity? Is it staffing and just not feeling that time constraint? Or is it all three? Is it kind of
Sure, I'm not sure what's motivating it, but I feel like a lot of nurses, I feel like it's probably pretty complex, but I feel like a lot of nurses, and honestly, recently I saw one of our graduates from a few years back say that, I wonder if they chose the wrong profession. And I was like, wow, and then, I thought it would just be the one, but then a few others were commenting that they felt the same way. And I was like, wow. And for me, I almost felt like I had failed my students, because I was like, did I not prepare you for the reality? Or is there something about the reality that we really need to consider? It needs to shift. It needs to change. There's something wrong. And I told you about my experience of just, there is an academic practice gap. There is. And I think sometimes in education, I feel like this is true, that a lot of times we speak to what should be like the ideals, because we can do that in academia. We have time to develop our curriculum where we're teaching them, best practices. And I know that this stuff happens in the real world practice, but I also know that, sometimes, for example, they used to say, well, when you take a test, that you have one patient. When you're answering that question, it's one patient. And so I understand in the real world practice, you don't just have one patient. You have a lot of different pressures. But I don't think that still should negate doing, what we know to do to keep our patients safe and to be an effective nurse. And I do feel like we need to continue to empower our students. I know I was having a conversation today in lecture, because it's that professional identity is really important. You can be a nurse and just do the things, or you can be a nurse and really feel that role and really say, hey, I'm going to do the best in this role, and really, let yourself put all of yourself into it, I suppose. So I feel like, in lecture today, I was telling my students, listen, don't ever feel lesser than, don't ever feel intimidated. If you have a list of orders, don't ever think that you must do them all. I said, you are a nurse. You need to think through what you're doing. You need to make sure you understand what you're doing, and you need to make sure it's the right thing. And if it's not, then you need to advocate for your patient, and that's okay. Don't ever let anybody make you feel lesser than, because that is your role. And so sometimes I feel like, if you don't have that strong sense of nurse, then I can see them going into the practice setting and maybe just getting overtaken and overwhelmed and overcome by what other people are role modeling and what other people are doing. So those are just some of my additional thoughts.
Yeah, I had a link prepared for Nelda Godfrey has been a leader on developing professional identity formation for the last few years, and she's got a wonderful website at the University of Kansas. But one of the things I think that's really important that Nelda's work really resonates with me is that when you understand the definition of professional identity, nursing is not something that you do, it's something that you become. And it's establishing the identity that you are a professional nurse and embracing the values, kind of like in the military. You have that sense of what it means to be the few, the proud, the Marines.
Mm-hmm.
And that identity is something that you own and develop and it's part of you. It's not something that you do, it's in you. Kind of like the Gatorade commercials and Michael Jordan. But in essence, I think that's where we need to really just kind of help our students to see. One thought that I'd like to share with both of you, and then we're going to go to some of the comments. We've got some great feedback, is that I'm going to go to you, Marina, and think that I think some of this begins with the lack of integrity that students demonstrate in academia that we tolerate, the cheating culture and the taking shortcuts in school that is just almost culturated now. And we literally, I don't know, how we get our head around that, but in essence, we're taking shortcuts, and it's basically normative to a certain extent, unfortunately. So then it's just a very small step to take a shortcut in practice. It's the same principle, and that's why we must have a complete zero tolerance of academic integrity, because I think that it trickles down. I think these two could possibly be connected. Now, Maria, I know you're passionate. Am I making sense, or would you agree, disagree?
No, absolutely. The research shows that students who cheat in school are more likely to do something unethical in the workplace. So the research is there that proves that. That is why I am so passionate about academic integrity. It all starts with education. There are some people who on the post, when I posted that, we've got to do something as educators, there were a couple of people who said, it's not our fault, we're not doing it. And I never said it was our fault, but it's our responsibility to be a solution to the problem, because it does start with us. I forget who said it, so I apologize that I'm not going to give the person credit. But there is a famous quote that says, how you do anything is how you do everything. And we need to think about that the next time, that we want. Let me say this. You're going to get me on my soapbox.
Yeah,
I'm going to get on my soapbox. But I want to say this. We as instructors tolerate cheating. I have spoken with educators who say it's not worth the trouble to report a student. It's not worth the trouble to have this conversation and go through all the channels and all the paperwork and all the red tape that it's going to take to bring this person up, on academic integrity charges, if you will. And I'm here to say that it absolutely is worth it. We don't have the time not to do this, because when you look up in the hospital and you've got that patient standing over you, physician or nurse standing over you that cheated in school, how are you going to feel then? And that has happened too. I've heard many stories about a nurse educator going into the hospital, and they get that nurse who they did not want to graduate from school, but somehow made it. So I'm telling you that it's serious. And I agree with what Lisa said about professional identity. I was proud and still am proud to be a nurse. And being a nurse to me means that I have integrity and that I'm honest. And I will uphold that. And I will be sure that those nurses around me will uphold that. And we all need to have that same attitude and that same level of caring. And we need to instill that in our students, because what they do in school is what they're going to do at the patient's bedside.
I love that. And I just want to add to what you're saying, with the cheating, absolutely. But, another thing that I feel like can contribute is students sometimes, or for us, I like what you're saying. We have a responsibility to be part of the solution. Sometimes we emphasize that test a little bit too much and don't help them see the bigger picture of actual real world practice. Now, this is why I love clinical education, because it's this constant reminder of, hey, there's a real patient here. And so I think sometimes with too much emphasis on the test, on the NCLEX, sometimes our curriculums are built to get through that NCLEX, are they not? But then what are we actually saying to students? And what are we saying? That just do whatever you need to do to get through that test, right? Does that reinforce the learn it and dump it syndrome? Does it reinforce the cheating? I just got to get through the test. I don't know. But I do know that we have to constantly remind students that there is a bigger picture, that you're not just learning this stuff to get yourself through this test. You're learning this stuff so that way you can do good practice and save a life, make a life better, be there with somebody in their most vulnerable moment. You're the one that gets to be with them. That's how much of an honor that is. So, I mean, I feel like that's got to be part of the conversation, I think, when we're talking about this. So,
and it's almost like we've got to have a patient-centered curriculum, that everything is revolving around the patient, not the NCLEX.
Yes,
Which is a necessary step.
yes.
But let's put first things first. And I think that's where we've missed it. And that's why even Dr. Benner and Educating Nurses, a call for radical transformation, addresses the information, the infobesity that's all about the test. And it's like, we're still, this was published in 2010, 14 years later, we are still yet to realize this transformation. And, I'm only one person, but this is the book that sparked my passion as a brand new educator to bridge the gap. I didn't even know what the gap was, but I saw it as a brand new educator 14, 15 years ago. So, the problem still remains. And, we're going to get to solutions here in just about 10 minutes or so. But what I'd love to do is that we've got some great comments in the chat. We got to honor our guests, our faculty who are here live. They didn't have to be. They could be grading tests or something fun. I don't know, but or care plans. That's even worse. But you're here. So let's honor you, and let's just give you your time to just kind of just comment on your comments. I'll just kind of pop them up real quickly. We'll go through them. Shirley says, nursing preceptors play a role in this too. Is that kind of, I'm assuming, the enculturation that we're seeing role modeled by preceptors in practice is what Shirley's commenting. I think we see agreement there. We talk, as Sarah mentions, we have to provide students or educators with the tools to challenge these practices. And you'll be talking about one solution here later on this in this webinar. But yes, tools are needed. We'll talk about that in just a little bit. Beth, who's been with us before, says the expectation of practice is a lot higher than years before. I think what you're referring to, Beth, is the complexities of practice are also, they get higher every year. And are we preparing our students for the complexities of multiple patient assignments? Are we doing simulations, etc., that replicate, what they're going to see, so they're prepared for battle and don't become roadkill?
And Beth, I love, and Beth too, because I think the conversation at nurse education is shifting a little bit to, are we supporting them when they graduate? Because now I think we've realized more than ever how important those, residency programs are. That the nurse educators, we are doing our darndest, and we can only get them so far. But to develop these complex skills requires more years than a typical education program may be. I know a lot of us, I'm from an associate degree program, they get 2 years. And clinical judgment, which is really, really important and integrated in so many aspects of nursing care, it takes at least 3 to 5 years really to get yourself to a good, nice level, is what it seems like they're saying with the studies. And so, if that's the case, then that is going to be that year of the residency program that they kind of finish them and help develop them. So, I think that having more of these academic practice partners is going to be so important, because we're going to have conversations then about where can we get them to. And then here, just like we do from semester to semester, we know our curriculum. We know first level students get to this, second level, third level, but we don't have those conversations far enough between, okay, well, now they're a graduate, so this is kind of where they left off as graduating, and then where are you going to continue them? So anyway, I just wanted to comment on that, because I feel like that's a really important conversation happening right now in nurse education.
Right. And as we talk about the academic practice gap, it really is a partnership between academia and practice working together. And those nurse residency programs are a crucial link into that responsibility. So,
can I say something here since we're talking about residency programs? I'm curious, those of you that are on, we've got a good crowd. I bet somebody here was at the NCLEX meeting today. If you were, just say yes in the chat, because I'd like to know how many of you were there. They actually did something they'd never done before. They invited 4 practice partners in. And if you heard them talk, they all talked about using Lassiter's clinical judgment model, which of course is based on Tanner's clinical judgment model, or Lassiter's clinical judgment rubric based on Tanner's clinical judgment model. And they all talked, though, about the importance of having that measurement tool. They talked about the importance of having the same language, using the same language, that Lassiter's rubric allowed them to use the same language. And I just thought, ding, 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 ding. If we were using this in our academic settings, how much further ahead would our students be when they go to those residency programs? So I see that several of you were there. I know you heard all of it. What wasn't the whole session with the practice educators, to me, was just eye-opening, and I'm going to say it, but it was just almost like a pat on the back for to Keith and what Keith has been doing and preaching, and Lisa. And I think they even used one of Lisa's articles as a reference when they were doing the presentation. So I want to say to you guys, kudos. You're on the right track. You've been on the right track, and NCSBN is coming on board, I do believe.
And this is where we as educators must take responsibility and act on what the NCLEX said today. And what that practically means is that if you're teaching students an NCLEX examination measurement model to inform practice, and you're teaching them the steps of prioritized hypotheses and using that language, that needs to stop. Tanner's framework aligns with the NGN, aligns with what the ultimate NCLEX case studies. They need to understand the language, because we haven't used that language. I've never used that language in 36 years of practice. And I wondered, why are we teaching students? And it's like, I've been on that, Maria, I was kind of a lonely voice, though, because a lot of prominent voices in nursing education who were much more popular and bigger than me were saying, teach the NGN and show it to students and do all of this. And I knew in my gut that was a wrong path, but it wasn't well received at times, but yet I stuck to it because I knew in my heart it was the right path.
Well, NCSBN said today, I wrote it down, and so put it in quotation marks, but NCSBN said today that the National Council Clinical Judgment Measurement Model was a model that should be used to measure clinical judgment on NCLEX. And Nicole Williams, the associate director, even later said that clinical judgment frameworks are not our specialty. So that message is very different from the message that I've been hearing for the last few years.
Yeah, and I love that they said that, because I think that, if you're at the point of the NCLEX, then you're already assuming that these students have learned some of these skills. And so I've been saying, if students are going to learn how to analyze, the cues and recognize the cues and everything, then first we're going to need to learn we're going to need to teach them how to do noticing and how to do focused observations and focused assessments and know what they're looking for. If you're not teaching them what they're even supposed to look for, they're not going to recognize anything because they haven't been taught that. And so there's a lot of skills that are part of clinical reasoning that we can teach, we can expose them to in clinical education to really help them develop that. So yes, they can pass the NCLEX. Yes, they can recognize deviations and changes in their patient's condition in real world practice when they're a new nurse, because that's one of the biggest gaps right now is they're concerned about these new grads not recognizing decline in patients and failure to rescue. Those are the big issues right now. So yeah, I love that they had that conversation, Maria. I'm glad you shared.
And I would just share one closing comment is that I think the real another takeaway for us as educators is the importance of adopting as a theoretical framework in our curriculum a practice-informed framework of clinical judgment, which is exactly what they're saying. And when you look at all the clinical judgment frameworks, there's one that rises to the top, and that's Tanner's clinical judgment model and its alignment with Lassiter's rubric that breaks down those noticing, interpreting skills step by step. Again, developing the clinical judgment with practice-informed language. So I want to challenge every educator who's listening to this live or on the recording to really take a look at, looking at how we can implement needed change to strengthen, again, our practice and clinical judgment. So that was a fun bunny trail, Maria. Thank you for sharing that. Maria, I'll let you. Do you have some comments that you want to highlight in the chat? I'm gonna, have you had a chance to scan the chat? I don't know if we're gonna get to them all because there's a lot, and we've got a few. We've got several more minutes before we'll talk about some solutions and other strategies. But I just want to know if there's anything there that stands out to you that either.
Well, I think this gets us to the solution. So I am going to highlight Rachel's comment here. She says we need to do more training of our clinical adjunct faculty. They are expert clinicians, but need pedagogical training. And that is so true. We talk so much about the academic practice gap, but I say there is a practice education gap because we're taking those expert clinicians and they're now novice educators. And we kind of forget that. I know we forget that because I was one of those people who was, master's prepared nurse practitioner. So it was assumed that I knew how to teach. And so I was plopped in front of a classroom and handed a syllabus and said, have fun. I had no clue what I was doing. And there are many of us in that boat. So I think that kind of gets us to going with the solution. So I'm going to leave that there.
I love that you said that. Actually, I had a similar conversation. I had a conversation with one of our clinical adjunct instructors today. She came to my lecture today, and she's come to my last several. She said, you know what? I feel we were talking about there seems to be like a theory clinical gap because now I am very fortunate that I get to teach clinical, but I have one out of 8 sections. And so a lot of times we do have those part-time clinical instructors teaching clinical and they don't really know what we're doing in theory. So she made it a point to come to the theory class because she says, I really want to make a difference to these students. And I feel like I need some guidance and I need to know what they're teaching, what they're learning about in theory. And I'm like, you're absolutely 100% right. Like we need to bridge that gap even within our own nursing programs. And there's lots of different ways that you can do it. But I thought that was, a really powerful kind of moment, a reminder. And I do remember being a new clinical instructor myself, Maria, and I had a similar experience. I was like, well, I don't really know how to do this, but I guess I'll just show you how to be a nurse. I'll just show you what I do in a day. I'll just show you that. But then when I realized, I was like, well, there seems to be like a science behind this. And I was like, I better go for my master's in nurse education. And then I learned, and I was like, oh my gosh, there is so much. Like, how do you deal with different developmental levels of students? How do you challenge students without breaking them? How do you question them and get them thinking and on the right track? How do you help them explore? There's so many things to teaching that I think we take for granted sometimes, especially the seasoned educators too. I mean, because sometimes you see this in practice. You have seasoned nurses that are like, oh, it's easy. You just stick the needle in, you're done. But for a new person, it's like, no, you have to think about every step of it, And so this is the same way with nurse education is that we can't, don't ever assume if you're a seasoned nurse educator, you know a heck of a lot. And sometimes you don't even realize it, that we have to pass on these skills to, our clinical instructors and that next generation.
Absolutely.
And, I think it's obvious, but, when you look at just the obvious challenges of having 8 to 10 students in clinical or 4 to 5 patients on a med surg floor is such a different paradigm. But yet there's a lack of consistency in training of clinical adjuncts. Yes, they need that mentor, like Sarah said. Yes, they need the information to teach clinically well. Unfortunately, one of the current problems that we as educators must address is that we've got to have a consistent, we've got to be able to educate the educator. Just like they're not born a nurse, no expert nurse is born or, a nurse educator. They need that training, that teaching using educational best practices. And for some reason, as I look at the landscape of nursing education, we haven't figured that out yet, because I see voiceover PowerPoints on random clinical topics. I see, the lack of a consistent course that uses online best practices to concisely teach in just a few hours everything a clinical nurse educator needs, including the tools and the handouts and the documents to just download and use in their clinical to develop some of the key thinking skills and other approaches. And so with that, what I'd like to share and just kind of lead into is that, me and Lisa talked about this about 2 years ago at the Nurse Educator Conference in the Rockies, and we met for the first time. And I was, again, I loved her article back at that time on clinical reasoning, piece by piece. And we talked about the problem. And we began to kind of formulate a solution and saying, what if, one of the things that was in my vision was what about an online clinical course that's asynchronous? So you don't have to do it as a cohort, like I've seen in some, they're great content, but you only can get in here or here. What about you could access it in the middle of the night and you could do a module in 20 to 30 minutes and work through 12 modules that takes you from beginning to the very end of the clinical educational experience, and then provide CEs to meet some of the accreditation standards that are now allowing baccalaureate faculty to be approved and don't have to be a master's to teach clinical if they have a CE offering that is consistent and cohesive. And that's what we did with KeithRN. And Lisa's been a key part of that. I just want to say thank you, Lisa. You have been that academic bridge to really bring your colleagues together and some top dogs, including Sarah, who has commented on this post, and others. But the name of the course is called Innovating Clinical Education, Evidence-Based Strategies to Prepare Students for Practice. It's going to be delivered later this year, probably in November. But we have a landing page where you can basically just get more information at that link. It has an opt-in page to get a free tool, one of my favorites that'll be part of this course, connecting pathophysiology to practice, as well as with the email, we'll be able to provide you with updates, get you discounted pricing when it goes live as an early sign up. And I just wanted to kind of highlight just some of the things that it addresses. I'm going to let Lisa has written 3 of the 12 content modules. That's about 25% if I got my percentages right. So Lisa is a key contributor, plus she's going to help me review all of the content. But in essence, I'm just going to highlight the themes, and then we let Lisa share some of the things that she's developing with her content. But I encourage all of you who are attending this or watching this one way or another, go to that link, learn more, and be informed so you're first in line when we launch it later this year. But the essential, what we kind of start with is, kind of look at how do you transition to the role of a clinical nurse educator. So we have some key content. We're going to use video, audio podcasting, so you can listen to this course, you can view a summary, links, video in the course content itself on transitioning to the role, and have 2 modules on that. how to facilitate learning. You know, when we look at how do you facilitate learning, like Lisa talked about with clinical judgment and piece by piece, looking at teaching strategies, how to teach and develop clinical judgment. Another key role that doesn't get a lot of attention is providing the difference between feedback and evaluation of a student. How do you provide feedback without a student getting defensive? You know, there's a lot of challenges you face in clinical education that can kind of blow up unexpected. So we're talking about it, as well as having dozens of tools that you can immediately download as part of the course, you know, like your schedule for the day, clinical reflection activities, clinical judgment, clinical paperwork, and other activities that you can use. And so I'm really excited because it really provides concise content, asynchronous, with the tools to just operationalize. That's really the essence of even the membership platform that I developed several years ago, Think Like a Nurse, that does that with unfolding case studies. We're just going to kind of shrink it down and now have a complete course with the KeithRN tools, plus the other tools that every educator that's been a part of this project, including Lisa, will contribute that are just excellent. And you don't, and we'll just provide that comprehensive approach. And so, Lisa, I just want you to kind of
so
the content modules. I'd love for you to basically to share your thoughts and just what you kind of just anything you want to share with your content and what it should expect.
Yeah, I would love to. Let me first start by saying that, you know, I feel like the people that have come together we have been really having so many conversations, and you know, we want to make a difference. Basically, we want to make a difference in our clinical education. We want to make a difference. We know that a lot of us are hiring clinical instructors every single semester, so the turnover can be really intense as far as developing these clinical instructors. So this course was really a beautiful meeting of the minds. There's so many experts that have contributed to this course, contributed their knowledge. I just want to give a shout out to them. We have Sarah Kano, who's on the call, Rachel Sagaro, Sabrina Bilfeld, Shelly Buzzard, Janet Monagle, Alyssa. I don't know if I'm going to say your last name right, so I'm not going to try. And then and I feel
Sabrina Bilfeld.
Yeah, that Sabrina, but then Alyssa's also.
Yep.
There's just so many, and there's even others who are helping to review that, you know, don't even want to be named. They just want to do it because they love helping and they want to make a difference here. So I feel like you're getting, like, it's like a passion project for us. This is a passion project. We see a need. We want to make a difference. We want to make a difference in our own nursing programs. And then hopefully this will be helpful to other people, but we want to make sure we're really setting up these new clinical instructors and kind of getting us all on the same page, getting that information out there. So, I mean, some of the things that I was able to contribute is, again, I had to kind of think about, because I've been doing this so long. And so I had to think about, well, what is it that really helps me feel like I'm meeting my students' needs? And so I actually channeled a little bit I had done an integrative review with one of my clinical reasoning colleagues, Ann Nielsen, so talented, has taught me so much, so much. And so we completed an integrative review. And basically what we did is we looked at the literature out there and said, okay, well, who's teaching clinical reasoning, clinical judgment? And what are they doing? Like, what teaching strategies are they doing? What is that key? What is that and there's no necessarily magic key necessarily, but one thing that we realized was really important out of many things. There was a lot of strategies that were really important to use, but one of the big things that we realized, and I think this is applicable to clinical education across the board, is to be really intentional, to make some time in your schedule where you're actually dedicating to having some kind of like plan for the day, because clinical education, it can be really chaotic. It could be whatever you walk into. Students are all over the place. They don't really necessarily know what to do sometimes, the students, and sometimes the new clinical instructor doesn't really know what to do sometimes. And so you just kind of get whatever becomes. But it doesn't have to be that way. It doesn't have to be that way. If you have a patient, a few patients, one patient, a few patients, you have a clinical experience, and you can make a plan for the day. You can make time for debriefing. You can make time for questioning. You can make time to really break down so many aspects and pieces of nursing, but you got to make sure that you have a plan for the day and you carve out some dedicated time, because if you don't, you know what happens. Your students are pulled over here and, oh, we're short staffed. Can your students take vitals for the whole entire floor? And it's like, well, we could, but then we're not learning all the things that we need to learn. You only have to do vitals so much. And yes, it's nice to do things like that for the floor now and then, but you have a whole slew of things that you need to help these students learn. So you really need to kind of create that space where that kind of learning can happen. And, I say organized. You want to make a plan and organize. And yes, really these cool spontaneous moments are going to happen in clinical, and you want to take advantage of those too, but you want to go in kind of with a plan. And so some of the things that I contributed were just like, how do you make a schedule? How do you make a plan for the day? How to make time in your day for pre-conference, mid-shift conference, and post-conference. I've been talking about mid-shift conference for a while. I think it's really, really important, because it's almost like I view a clinical experience from a student's perspective can almost feel like a simulation sometimes. There's a lot that happens with a patient encounter. And to be able to take a step back from the unit for like an hour and a half, 45 minutes, whatever you can carve out, gives them time to kind of process what they're seeing, get some feedback from you, share some thoughts with the students, but yet they still have some hours left in their clinical day where they can take what they just recently learned from that feedback and debriefing session, and they can go back in. They can go back in and apply that knowledge. They can revise their care plan. They can revise their approach. They can evaluate the patient. And so having those times in clinical where you carve out that time is really important. And then just things like facilitating learning in the clinical setting. So how do you use how do you make things become more active learning? I think one big thing that we see in clinical education sometimes is that we assign a student to a nurse. And sometimes you have to, because they're off the unit, they're having an observational experience. You can't be everywhere. It's just impossible. But does the student know what to do when they're with the nurse? Does the nurse know what the student needs to do when they have that student with them? And so just being able to create some activities that the student has, some learning activities to kind of guide that experience still. I think of these learning activities kind of like, because I create a lot of learning activities for my students. And so I think of them kind of like these things that if I'm not with you, I'm still with you in spirit, because these are the questions that I would be asking you. And these are the things that I'd be having you do. So that way it's not like the student feels lost and alone and doesn't know what to do. It's like, no, focus on this activity. This is what I want you to be doing today. This is going to connect with your learning in theory. This is going to connect with your objectives. This is going to connect with the outcomes that we need to focus on. And one of my colleagues wrote to that as well, too. How do you align your teaching with meeting the course outcomes, with the objectives for the day? And what does that mean? Because clinical instructors sometimes, if they're not full-time faculty, they're not as far as time-wise, they're not invested in the development of the curriculum and understanding how all the course and program outcomes work together and align. So there's just a lot of practical tips here. And I know that we looked, always looking for feedback from fellow nurse educators of things that you feel like would be important to include in like a course like this for your clinical instructors. We have information about how to give feedback, assessment and evaluation types of strategies. How do you manage challenging situations? How do you identify a mentor? My colleague Sarah Kano wrote that section. How important it is to have a mentor. I tell my students this now. I say, you want to get somewhere in life. You want to be a good nurse. Do you want to be a good student? Don't make things hard for you. Find somebody who's already done it and ask them what to do. And I'll have a few people that are your mentors. It doesn't have to be, you don't have to pave your own path all by yourself. There's been so many people who have done this for you. Find a mentor, identify a mentor, be a mentor to somebody, help guide them through it, and create a safe space for that person to learn. And that's the case for students too. So that's another thing that's in there is how do you create a space to empower these students? Because back to how we started this conversation, these students need to be empowered enough to speak up for their patient when things go wrong. And there's pressure in the healthcare world. I know people are scared to call the rapid response the code blue because they're scared they're going to get yelled at. But there's pressure, obviously, now with even making sure we're doing best practice. So we need to empower our students and create a safe space where learning can happen, where mistakes can happen, and that we're going to continue to guide them along. So a lot of good stuff. I could probably talk so long. So I'll pause for
Yeah,
now.
no, I will just to Beth Corner or Beth Crockett Corner, who was actually here tonight. And Beth, she wrote a lesson on basically eliminating clinical paperwork step by step, semester by semester, how you can go from several pages in the first semester to an oral care plan, just like a nurse in practice. Can you process and synthesize your thinking orally? All you have is just your patient's cheat sheet for the day, just that patient prep, Cardex data, but otherwise everything else is done right here at the end of the fourth semester. And they're doing that at Med Michigan. And Beth, I asked her to write a lesson. How do you do that? And so I really see this course as really empowering every clinical educator to implement educational best practices, innovative strategies, and do it in a way that, again, like Christine says, we need debrief activities. Guess what, Christina? We've got worksheets for debriefing that will help guide you and just empower you to immediately, bring about, to bring, these activities that Lisa shared. She'll have some handouts on that with those learning activities. And so I'm just really excited. So I know the need is there. And, I've always been about trying to help educators, serving their needs to create solutions. And let's bring about change. We don't have to let the gap be what it is. We can bring it, we can bring it down in this generation, and we can bring it down, within, it's going to take time, but we all have to be a part of that change. And so I just, I'm tired, but I get excited when I see, I'm getting gray. I'm getting grayer every year. Even my hair is getting gray, which never was. But, I've got limited time, but I want to do my part to contribute to the solution. And Lisa and Maria are just a blessing, and kind of like, holding my hands up like Moses. I'm tired, but what it's like, keep me going, because that the need is still there. And so thank you for all that both of you have done to support the work of KeithRN and this clinical course. And if anyone has any questions, feel free to put in the chat. We just have we'll wrap it up in just a couple minutes. But what I will share in closing is the link again. All we have right now is a landing page. So if you just want to get just like more information saying, yeah, that sounds good, get the free tool, and, we'll keep you in the loop. We're not going to spam you. We'll just kind of keep you in the loop as we have new updates, and when we have this ready to launch and tested and ready to get it out there. And so if we get it up by the end of the year, it'll be a resource for your clinical faculty as a program, and it'll be purchased as an individual or at a programmatic level at a discount. More importantly, if you're a Think Like a Nurse member, and I know a lot of our program departments will say, well, let's just get the Think Like a Nurse membership for our classroom faculty. This will be less expensive than a discounted faculty to the Think Like a Nurse membership, and you'll get an additional, at least a 25% discount as well. And you can purchase your seats for your clinical adjuncts, and they can take it from there. So this is really, I think, going to be a solution to, even though we have great resources for clinical teaching in the membership, they just say, well, we'll just stick with the full time. This will be a needed, again, just kind of bridge that gap. So.
And I just want to say one more thing, if that's okay, because this came out in the chats. I saw a few people say something from it. One of my colleagues, Robin, had mentioned it, is that it's really important for us nursing educators to advocate and feel empowered that we ask for the structures that we need as well, too. Because a few people had mentioned that our clinical groups are so big and this and that. So if we know that we need smaller clinical groups to be able to provide that quality education. We know that we need, more faculty development, more training. I just want to encourage us to advocate for that, to bring in the literature, to share the findings, and to keep working towards putting these structures in place so that way we can have what we need, so that way we can give our students what they need. So I just empower everybody.
Amen. Well, thank you,
I
Lisa.
will just add to that quickly. I spoke to a school this week in Massachusetts who said that they have grant money provided by the state for faculty and student retention. And they are using their grant money for Think Like a Nurse membership. So if you have grant money somewhere and you can use it, even for retention. I mean, she said this is exactly what I need for retention. So just throwing that out there, because I talk with a lot of people who want the membership, but the money's not there. So
Yeah.
consider grants.
Yeah. Very good. Thanks, Maria. And other than that, we'll go ahead and wrap it up. We'll be here next month, second Thursday of each month at 7 p.m. Central. And so we'll have a topic yet to be determined, and look forward to connecting with you all then. And again, thank you for all that you do as nurse educators. You are making a difference. And I know that we kind of had a negative start, but I want you to just kind of see that there is light at the end of the tunnel. And every one of you who are part of our profession, part of the important and incredibly valuable work you do as an educator, you know what? Together, we're part of the solution, and we can do this. We really can. I wouldn't be doing what I'm doing if I didn't believe that with all my heart. So I can't do it alone, but if we link arms together in your programs, be an advocate for change, we can bridge this gap. And so let's all just resolve in our hearts and follow our heart, mind, and soul and spirit to do just that. And it's a pleasure to partner with you. Maria and Lisa, thank you again for joining us, and we'll see you all next month.